We're going to pound through this. There's a lot to go through with two sort of separate topics: SI joint fusion and pelvic fixation. So we'll just blast away and do the best we can in the next 30 minutes. So just a primer on SI joint motion. It's sort of they call it nutation, which is sort of an oscillating rotation. It does move, but not very much, less than 4 degrees for most, unless there's gross instability post-traumatically or something like that. And you can see males tend to have a little less motion than females. It's a suspensory sort of junction between the sacrum and the pelvis, but it still does that bit of oscillating rotation and what they call nutation. SI joint pain that comes from that joint is fairly prevalent. There have been different studies on this, but if you look at just chronic low back pain, I think the better studies are somewhere between 10 and 15%. Sobrano and Polly did this study in 2009 and came up with this 14.5% number. I think that's probably realistic, and there's likely to be varied degrees of severity in that 14.5%. I sort of think of it in the 10 to 15% ranges for practical purposes. Post-fusion seems to be higher. You can see on the right, different studies have been done looking at those who have undergone fusion. These are not deformities, just degenerative fusions. And about a third, I think, is a good number to hold on to if patients will develop some level of SI joint pain related in part to that fusion being there. And we'll go over why that's the case. It has to do with adjacent segment deterioration or stress, we believe. There are changes both on an imaging basis. 75% of those that have lumbar fusions will develop degenerative changes in the SI joints based on CT scan evaluation within 5 years, while only 38% of age and gender match controls had those changes without fusion. So there's something going on that we induce from stiffening the spine or from ankylosis of the spine when we don't operate on it. And this is likely because of increased stress at the joints. The joints got a synovial type of component to it. There's hyaline cartilage, type 2 collagen, and so it deteriorates or degenerates in part, just like many of the other synovial joints, cartilage-based joints that we have. But it typically doesn't ankylose over time. You guys have seen in clinic looking for Fortin sign or pointing at the PSIS. It's a reasonably sensitive finding, not highly specific, but reasonably sensitive. And then the 5 maneuvers of Faber, Gainsland's thigh thrust, compression, distraction. Those are good to be aware of, know how to do them. It is not an imaging-based diagnosis. It is a physical exam and history-based diagnosis. So you want to get familiar with them. They can be tough with big people, large thighs. As you've seen some of the clinics, the beds need to be conducive to doing it. You have to have a bed that's low enough to actually get above them. If the bed's pretty high, you almost have to climb up on the table to do them properly. But it's something to look for in your practice and make sure, ideally, that you have the capacity to do these exam maneuvers properly, or you probably underserve patients by not diagnosing when you need to. The 3 of 5 positive tests do a fairly good job of discriminating and get your sensitivity up to about 91%, 85 to 91%. Still not highly specific, but it gets you into the ballpark of concern for sending patients on to diagnostic injections and further confirmatory measures. The injections that we've all talked about many times before can be challenging, mainly from getting patients on the same page as to what to recognize, and certainly the pain docs don't often facilitate that for us, so you really have to educate them before you send them. It's part of the rationale for having them go through 2 injections, because the first often is both diagnostic and therapeutic, and then the therapeutic component's more focused upon. There are different guidelines for different societies. But in general, between ISAS, NAS, and these other societies, somewhere between 50 and 75% pain relief is what you're looking for. I tend to like it to be a little higher. I like the 75%, but you can theoretically use either. Again, the second injection typically, preferentially, is going to be a diagnostic only with a low volume. It's about 1 cc. There's different numbers out there, but you don't want to flood the joint because the joint can have some effusion of the material out of the joint if they flood it, and then you get some treatment of external structures and false positive. Treatment usually is pretty successful through physical therapy, and so I would advocate that pretty vehemently. About 2/3 of people will respond to physical therapy for pelvic and lumbar stabilization exercises that actually get the SI joint in better control. Remember, there's a bit of a motion issue, and muscle control can lead to more pain. Another thing you'll be confronted with is whether to send patients or advocate for RFA. The RFA in the SI joint, on the upside, probably doesn't have the dramatic downside we see it have in the more mobile spine, where it denervates the stabilizing musculature, we think, anyway. On the downside, it is not highly successful. There are different types. There's traditional RF and cooled RF. The cooled RF reportedly has better results, but you're still talking about a 30 to 50% success rate, and it's short-lived at that. And then there's SI fusions, which historically were pretty morbid, pretty bloody, open operations, and the trauma to the surgeon and the patient getting them through that was pretty overwhelming, and I think not many people did them because of that. They could still derive benefit, but it was a little bit challenging to get people through it. So the less invasive maneuvers that we have now to cross the joint and get it to stabilize and fuse appear to be have the upside without the downside of the approach and exposure. This is the InSight study group that Peter Wang did or led the charge on, and it was a prospective randomized trial. And you could see with non-surgical management out to 6 months, there's really no change in the ODI, and pretty dramatic drop for the iFuse or fusion patients out to about 2 years in this initial study. And here you see the success rate, 82% at 6 months, satisfied at 90%, and maintained out to 2 years at 88%. So pretty respectable change in clinical improvement. This is the IMIA study that was out of Europe, and only 6-month results, but same sort of findings where you get patients drop into the moderate disability profile from severe disability, and maintain that out to 6 months. Another study, prospective, multi-center, almost 200 patients with 2-year follow-ups, and you can see them commensurately dropping in their ODI and VASs. There are some other studies out there looking at SI joint fusion. This is retrospective, but 97% fusion rate. No HRQOLs on this one. This is another one with a different type of device, very small numbers, no fusion rate given, ODI, HRQOL is not provided. Some VAS improvement, obviously, but limited duration. So I'm going to whip through these in some sense to show you that there are different options out there. The challenge is discerning the data. The data is not prevalent for most of the devices, and including something I think you heard us talk about recently, which is these allograft plugs that go into the SI joint. So we really don't know how they work from a clinical nor radiographic perspective. If you look at the SI joint fusions and how they tend to lead to improvement, you can see here this many studies up here looking at the drop in the ODIs into the less disabled realm. Durability obviously was a big question initially when we were using devices that would cross this joint. Not totally sure about their capacity to endorse a fusion eventually, but you can see here if you take these studies out to after 2 years, you get this maintenance of reduction in disability profile that's reasonably substantial. And here's another one out to 6 to 7 years compared to conservative management. So a sustained benefit to SI joint fusion well after and likely durably following SI fusion. What about revisions? Revisions are out there to be sure. Some for malplacement, malpositioning of implants. So we've seen implants placed into the sacral canal. I don't think anybody here's done that, but they've been revised here. Hopefully we don't see that done on our watch. But if you look at this large cohort of almost, 11,300 patients, you see a 3.5% cumulative 4-year revision rate. Seems high, but certainly worth knowing that nothing's perfect. And I would suspect some of these are malposition versus poor healing. And so be cautious about putting them in, but at least know that if when you do this sort of thing, your capacity to make people better on a long-term basis without a substantial risk of revision surgery, and certainly lower than what we see with most of the other reconstructive surgeries we do, is reasonable. This is a Pearl diver data extract early on I would say in the learning curve in the process of doing this, and you see an overall complication rate of about 16% by 6 months. So not a perfect sort of surgery in terms of complication rate, but commensurate, if not better, than most of what we do reconstructively. This is just to look back at open fusion rates. So it's not that we didn't do it and have success. You can see they still got significant improvements in VAS HRQOLs and had a modestly respectable fusion rate, I suppose, given the circumstances. But again, the morbidity and pain for everyone involved was tough. So I'm going to pop forward because I want to get to the pelvic fixation before we get too late. Let me just bring that up. So in summary, SI pain is real. You got to look for it. Again, it's not an imaging-based diagnosis. We also mentioned this on one of the last calls, based on some of the things I've learned from Dave Pauly and others, the inflammatory arthritides, such as Hank-Spahn, or those that cause SI joint pain, do not necessarily respond as well to surgery. So you may not be looking for those patients as much as post-traumatics, post-vaginal delivery patients, or degenerative type of deterioration of the joint. It can definitely improve the clinical outcomes of these patients. And then mechanically speaking, you need multiple points of fixation because it's a rotational type of joint. If you stick one across, you're liable to fail. 2 is better than 1, and 3 is better than 2 in terms of points of fixation through this joint. So be thoughtful of that. I kind of blasted through it, but the health economics of this sort of surgery, SI fusion, are quite favorable with respect to what you gain in qualities and quality of life, and the sort of health economic equations that we try to put our treatments through. And then MIS obviously is typically the way that we've evolved to doing it, and it seems to be both successful and reasonable to do. So just to show you, I'm going to relive this with Ali, who I think was a fellow at the time. We were laughing about it the other day. This was my first case, so don't make this your first case. This is a 78-year-old lady who came following multiple injections in the Inland Empire. She had horrible back pain and had a mobile spondy, but they had been injecting various things, including her SI joint. and she was disabled by the pain. We had an MRI that looked like this, looked quite worrisome, an erosive change in the joint. So her labs were elevated. She clearly had an infection, and so we treated her with open debridement, IV antibiotics. She had some of her pain improved, waited for her laboratory studies and system to normalize through that infection, but she continued to have severe back and left lower extremity pain. So we did an SI joint fusion, which looks okay on this X-ray, but was very difficult radiographically because she was morbidly obese. And I wanted to do this for her to try to get her some relief, and I didn't feel like this was a purely elective circumstance, but it was not ideal. And I think today, and we didn't have it then, I would probably think about using NAV because we were really challenged with imaging. So she had that, and then eventually came back, and we took care of the problem that she really had, which is immobile spondylolisthesis at L4-5 before the injection parade. All right. Any questions about SI fusion before we get into pelvic fixation and apply some of that? No? All right. So there's lots of different pelvic fixation history. Galveston technique you see over on the far left. There's the traditional iliac screws below that, and then stacked iliac screws. S2AIs came about. Now we have stacked S2AIs, and finally now we're thinking about prophylactically stabilizing the SI joint in a more rigorous way. Why are we starting to do that? Well, because of research like this that we've done that really suggests that we've got some issues on the caudal end of our deformity constructs. You can see here with the ISSG data set that we had a pretty humbling level of loosening of screws, iliac fixation of any type, S1 screw loosening, screw fractures of the iliac fixation or pelvic fixation, and rod fractures as well, often below S1 rather. Chris Martin did this more recent study out of Minnesota, a multi-center study, and really was looking at early failures of a lot of these constructs. And you can see that they had set plug dislodgements and sacral fractures, really catastrophic things that would happen early in the first 6 months. You can see another sort of series of imaging studies looking at a failure. The failure cases tended to be large magnitude, deformity corrections, and the failures seem to be caused by stresses that exceeded the failure loads of the set plugs. The revision strategy has generally been 4 rods crossing the lumbopelvic junction, and sometimes even 6. But bottom line is, the learning point from this study is the biomechanics of the caudal aspect of the construct matters, not just numbers of rods, numbers of screws, but the mechanical fortitude of the implements, the set screw torque outs, the neck diameter, and the screw diameter all have some role in failures or preventing them. So let me jump past this one. You can see here another relatively recent study by Hune, and they looked at spinal pelvic fixation complications. There's a summary of intraoperative and postoperative complications. If you look at it per screw, there was, you could see the numbers, 3.2% SI joint pain. And I would take these things with a grain of salt when you look at pain, because unless you're doing pretty rigorous physical exam testing and then injections, it's really hard to be clear about these rates. Reflecting on better quality studies where they found upwards of 30 to 40% when they put people through those rigors. But from a radiographic perspective, not unreasonable. If you look at the loosening of S2AIs here, 2.2%. Neck fractures, the S2AI screws, 1.6%. Shaft fractures, almost 0.5%, and then revisions in 1.6%. If you looked at it per patient, maybe 5 to 6% of distal device breakage and sacral fracture. But it's worth thinking about all these things, because if you tally them up, you get a pretty substantial number of issue. So if you look at why things fail, you'll see a lot of people use closed head screws because of the concern that these set plugs will dislodge and you get splaying of the tulip. Those are biomechanical considerations, and while you can get dogmatic, keep yourself on a biomechanical plane. In my opinion, you always want to know why things fail, resolve them, understand what you're using and how they resolve those concerns. Just because a closed head is there does not mean that the torque out of the set screw is any better or worse. It might be, but you need to know that kind of stuff, because the weakest link is what's going to get you. And if the weakest link is a torque out of a set screw, that'll get you. If the weakest link is the neck diameter of the screw, then it will fail through cyclic loading earlier than the set screw plug. So just understand the biomechanics of all of the implants that you're going to be using. Here's a look at another pain point, the spinal pelvic fixation complication systematic review. And this looks at a bunch of different studies, compiling about 700 patients retrospectively in 2 to 4 year mean follow-up, with the use of SI joint provocative physical exam maneuvers. And you can see here where their rates were. They range from 10 to 35% in SI joint pain. And keep an eye on the levels fused. Most of these were long constructs, but not necessarily T10 to pelvis constructs. So, probably a mix of longer and shorter constructs, and different types of implants in the pelvis. So reasonably compelling to be thinking there's an issue there. And getting back to the mechanics of the SI joint and why that might be the case, even with limited fusions, or if you have an ankylosed spine from degenerative change, you get a pretty substantial buildup in range of motion or stress at the SI joint. You can see here with just a single level lockdown at 5.1, you get a 52% buildup of motion at the SI joint. And with a 2-level fusion or lockdown, you get almost 170%. So pretty substantial. This is an FEA. And so we don't really have that data if you go longer, but presumably you're probably going to get a little bit more as you build in length of fusion. And interestingly, when the SI joint's constrained, and probably because it's not responsible for a great deal of motion, there's not as much adjacent segment sort of mechanical stress attributed to it, or that results from it. So that's just a compilation of what we just said. And if you look at Inoki's study on the far right, what he found was that the incidence of SI joint pain seems to climb as the number of levels fuses go up, from 6% with 1 level fuse to 23% with greater than 4 levels fused. So lots of potential complications with these different pelvic fixation modalities. How do you get around that? Well, you certainly have to look at bone density. The sacrum's lousy, as we know. The S1 end plate's decent. That's why we talk about tricortical fixations. Our famous Ryan Hole up here, who did this work, and looking at opportunistic CT scans to get that data, as well as DEXAs. The ilium has great bone, usually even in osteoporotic patients, and the most dense bone is found in the sciatic notch, just above that. And that's why we're trying to skirt it as closely as possible, typically, to maximize fixation. There are different ways of putting sacral screws in, just to cover that base, so you're thinking about it when you're putting screws in. The medially convergent screw, 30 degrees at S1, is better than the laterally divergent. Tricortical is better than bicortical, and then end plate purchase is better than parallel to the end plate. So the look up here on the right at this picture is sort of what you want to aim for in terms of fixation strength. There's also a study that Yupo Lee did at UCSD at one point, or maybe he was at UCI by then, but he even looked at going through the facet joint, substantially increased the fixation strength, which makes sense. You're grabbing better cortical bone through the facet joint at L5S1 if it's feasible. Here's a look at S1 fixation techniques and the medially convergent versus straight in or divergent. Keep those things in mind, given the failure rates that you'll see with this part of your lumbopelvic fixation. If you look at the rationale for pelvic fixation, it is that S1 screws are just relatively poor, particularly sustainably. They'll loosen even with good interbody fusion. We'll see that happen. And so both for fusion rate, which you see here from this study, and the need for durability, pelvic fixation's really taken hold and been much more common in longer constructs, and now to some degree even shorter constructs. Many espouse it for L2 and above on UIV. And I think with poor bone, I would even consider it at L4 to S1 or even L5S1 if you're deathly afraid of a sacral insufficiency compromise. So let me get through this. The traditional iliac screw with lateral connectors, that was the mainstay early on. It's easy to put them in terms of a starting point. You can see on the bottom right X-ray where those sit, and you could put large screws. The problem was prominence, and we resolved that by taking a chunk out of the pelvis to try to place them more deeply embedded, and then patients wouldn't be sitting on them. So that resolved some of the issue, but you still had offset connectors you had to hook up to. And so we started doing lower starting points, and you'll see Greg do that fairly commonly in the OR, and that tends to be in line. But when you're making the choice about what kind of screws and how long, there have been a few biomechanical studies looking at this. The 7.5 to 9.5 millimeter diameter comparison was done with the 9.5 millimeters performing best overall. And that should inform you two things. One, they're biomechanically better screws, number one. Number two, because of their greater diameter, they'll have less risk of fracture or cyclic load to failure. So you want to aim for more than 7.5 to be sure. The 8.5 versus 9.5 hasn't been tested comparatively to my knowledge, but certainly don't use a 7.5. I would say 8.5 or higher. Don't be shy about using the 9.5 or even larger, depending on what your circumstances are. The modified you see here on the bottom picture, that's that lower starting point. I think Vaquero popularized that, or his group. And you can see it's in line, so it sits much nicer and frankly even better than the S2 AIs in many cases. So it tends to sit closer to the dorsal sacrum and without the prominence, and again is in line. So I think it's a more common screw these days for the open deformity crowd. If you look at the S2 AIs, these are comprise about 60% of the market now in terms of who's doing what. Sponseller and the Calcabesh group at Hopkins popularized this technique, with the advantage being that you're a little more in line with the rods. You're taking advantage of the strong cortical bone at the SI joint as well as the notch. And mechanically, it tends to have a little better behavior than either the iliac screws or the traditional iliac screws. So you're biomechanically, you may be in slightly better stead using this sort of screw. The data, I would say, is not so compelling that you should use it, but it's something to think about. particularly in this this new realm of concern about the SI joint postoperatively, in which case you might want to cross the SI joint, stabilize it in more than one location to provide for long-term stability and prevent future pain generation, which remains a bit of a debate or a question mark. The screw length and screw head angle does make a difference. This is just an FEA as well, both iliac and S2AIs, but no interbodies, and they measured screw stresses, and they found that the longer S2AI screws with higher favored angled nature performed the best when compared to the iliac screws. All right, so in terms of using multiple screws, that's much more common these days, even in the circumstance of anterior interbody. But you're much more compelled by the data now, I think, if you're using posterior technique alone, to use a 4-rod construct at minimum to provide support across the lumbosacral junction. You want to be starting very low at the teardrop to get more than one screw in. So you have to be right above the sciatic notch. You can see that blue line, or the green line would be where you want to be if you're going to put more than one screw in, just so you leave room for yourself. You also have the luxury to put a kickstand rod. You can see that over here on one of the far right radiographs. Those will converge at the notch, or just lateral to the notch at the tip. So tend not to be as much of a problem in getting a couple screws in. But if you're going to put parallel screws like you see here on the left side, then you have to be hugging the notch. You see there a nice shot of a 4-screw construct. Again there, and there's a 4-rod, and then a 6-rod. So what about biomechanics? The biomechanics of the SI joint are such that you do get some motion at the SI joint, even with a construct in place where you use a single S2AI screw. Juan's group at BNI looked at adding additional fixation across the SI joint in addition to an S2AI screw, and it reduced the SI joint motion about 30%. So potentially beneficial long-term at restraining that joint's ability to both cause pain in the future and constrain it from compromising the fixation that's in place, fractures of the screw, loosening of the screw, or some other pelvic fixation failure mechanism. So let me bounce through this because I want to show you just technique from a placement perspective. And I know this is a sawbones look, but your S2 AI is going to be starting between your S1 and S2 dorsal foramen, and you're going to aim out similarly to the top of the greater choke, just like you do with an iliac bolt. And you might keep it slightly lower depending on the stature of the patient, because your S1 screw is going to be somewhere in this vicinity. And if you do put multiple points of fixation or use 2 screws into the ilium, then you want to leave some room here around the S1 foramen so that you can parallel your S2 screw. So if you look at this starting point, in order to capture enough sacrum, you might move this red dot slightly medially to get this all done. And then your S1 AI trajectory is going to start right on the lateral aspect of the foramen, the S1 dorsal foramen, with the targeting of your S2 AI at the base of the teardrop, and then S1 AI above that in the teardrop. So here's the recommended trajectory. If you're using nav, then you can see this skirting of the sciatic notch and the iliopectineal line here. So this would be your S2 AI, and then S1 AI would be a little closer to the iliopectineal line. To get those nice shots, you want your fluoro, if you're using fluoro technique, to be about 30 degrees over the top and 30 degrees Ferguson, and you can see a teardrop. For the most part, most people, you might have to play with those degrees a little bit to get the perfect shot. But you want to keep your S2 AI down here right close to the sciatic notch. This would be reasonable for your S1 AI if you're putting 2 implants in. There's a look at the diagram of that. 30-30. And there's a look at 2 implants in the teardrop, and really ideally how you position them. Again, sawbones, there's a look at your S2 AI in position already, S1 screw, and then a location for your S1 AI trajectory. Okay, and I think that's it. Sorry to blast through that. There's a lot to cover.